Good morning, and thank you for joining us for All Things Heart. I'm Alexis Del Cid. We are working hard to bring you some pretty incredible shows this coming fall. Until then, we'll be sharing some encore presentations of our favorite episodes every Thursday morning at 10 a.m. all summer long. So sit back and enjoy this best of All Things Heart.
From the University of Kansas Health System.
I am amazed. The team here is great.
I came on a Tuesday, and then by Saturday I had a heart in me.
I have never seen a group of people work together so good as this team of heart specialists. I mean, it's just unreal.
Stand by to set up show.
And the Dolph C. Simons Jr. Family Broadcast Studio.
Roll it.
Always makes you feel like you're the most important patient on the planet.
I felt heard, and that was really big.
This is All Things Heart.
Good morning, everyone. It is Thursday, April 14th. I am Jessica Lovell in for Alexis Del Cid today, and welcome to All Things Heart. Here is what we are talking about today. 20 years. That is how long Jenn Krauss knew something was wrong, but she simply could not get answers until she came here. We take an inside look at some of her symptoms and brain images that show what was wrong. And you know the saying, an apple a day keeps the doctor away? What about an avocado? How little do you need to eat to actually see the health benefits? And as always, if you have questions or any comments, you can share those on our Facebook Live, our YouTube channel, or you can email those to allthingsheart@kumc.edu. Dizziness, exhaustion, loss of awareness. A Kansas City woman knows these symptoms all too well. She went decades having seizures and yet was never given a proper diagnosis until she came here.
Before the surgery that gave Jennifer Krauss her life back, before she made it her mission to share her health journey with as many people as possible, for almost 20 years, Jenn lived a unique kind of torture that she sometimes endured up to 40 times a day.
So it was like an aura, like a deja vu moment. Like you'd been somewhere before, you'd seen something before, and you just kind of go dizzy. And just everything kind of just stands still and kind of, it's just odd. And then I would get this warm sensation over the whole left side of my body. And afterwards I'd get super tired, just exhausted, and then I would just sleep for hours.
Then the episodes got dangerous.
I was walking into a local store, walked in, fell face first on the concrete, and went into my first grand mal seizure.
It happened again when she was driving her 12-year-old son, who somehow had enough composure to turn off the car and slowly steer them into a ditch where he helped call 911.
And then from there I saw I think there was like 12 different neurologists. They never could find anything.
Jenn's world got incredibly small and isolating. She was no longer allowed to drive or do many of the other things we tend to take for granted. Using a knife in the kitchen, cooking over a stove, walking up the stairs, riding an escalator, showering unsupervised, because having an episode while doing those things could be deadly. To make it worse, Jenn says every single one of the almost dozen doctors she saw told her there was nothing wrong with her except possibly anxiety. Until finally she came to the University of Kansas Health System, where she met Dr. Carol Ulloa.
I wasn't surprised because it's actually relatively common that people have MRIs done in the community and are told that their MRIs are normal.
After 20 years of being misdiagnosed and misunderstood, Dr. Ulloa told Jenn she had epilepsy.
It was really quite a shame because she'd been having seizures for over 2 decades. And so the sooner you can pinpoint something like that and the sooner you can find it, then the quicker the treatment and being able to stop the seizures.
Stopping those seizures was Dr. Ulloa's top priority. Not only was Jenn in danger every time she had one, but there was another risk, one that doctors say was rare for Jenn, but is always possible with patients who have uncontrolled generalized seizures, what Jenn called her grand mal seizures. It's called SUDEP, sudden unexplained death in epilepsy.
And today we are so happy to have Jenn with us, joining us virtually along with her doctor, Dr. Carol Ulloa. She helped Jenn get her life back. And I am joined here in studio with cardiologist, Dr. Rigoberto Ramirez. Thank you all for being here with us today. So good to see you. Jenn, I've got to start with you. It's been a while since I've spoken with you. So good to see you smiling and happy. How are you feeling? Okay, go ahead. Okay, how are you feeling, Jenn?
I'm
feeling great. It's been almost 5 years now, seizure free. So coming up on my 5-year anniversary. I loving being able to drive, being able to go out. I do a lot of different things now that I wasn't able to do before. I go out and I hike a lot now, which is exciting. Able to do things in the water and stuff. It's definitely a freeing experience.
And when you say you're seizure free, you mean no seizures at all for the past 5 years? Not even a little tiny one? Nothing?
Nothing for 5 years. Almost.
Wow.
Well, 5 years next month.
Yeah, but who's counting, right? You're probably counting. Every single day matters, right? Dr. Ulloa,
Yes.
always good to see you. I have to ask, why did so many doctors get Jenn's diagnosis wrong?
You know, it's actually pretty common. And I think it's because the symptoms that a person can experience can be kind of strange and unusual and just not what a physician is used to hearing. Also because commonly anxiety, fear is a part of the aura or what the person feels initially. And for Jenn, that was the case. And because panic attacks are very common, a lot of times doctors then just kind of take that path and say, you're having anxiety, you're having panic attacks. And I've seen that quite a bit. And sometimes kind of hyper-focus on the panic part of it and maybe don't focus on the aspects that don't fit with a panic attack, you know. And so unfortunately, it is something we see commonly. I think the other aspect of it is the MRI lesion being missed. So because if a doctor knew that, okay, this person is having symptoms and they have an abnormality on their MRI, much less likely that they're going to say, well, this is, you know, just panic attacks. But that's something else that happens commonly. And when we've looked at it here, we found that about 30% of people who have lived with seizures have had MRIs called normal when they've had them done elsewhere, not at an epilepsy center like we have. But we actually find an abnormality. So 30% of the time, it's quite a bit.
So Dr. Ulloa, when Jenn came to you, why were you so sure after all those doctors didn't quite know what to do? Why were you so sure, I think I know what this is, and I think we can help her?
Well, it's all I do. So day in and day out, I'm talking to people with seizures and epilepsy. So as soon as she told me what she was feeling, I knew that it was a seizure. It has the correct symptoms. It carried that pattern. And for her, the medicines had not worked. Many medicines had not worked. And often it happened around her cycles, her periods. And that we see commonly as well with seizures. So then at that point, it was just a matter of sort of figuring out the next step.
Yeah, she was finally in the right hands. Jenn, that must have been relieving just to finally hear someone say, we know what this is and we're going to be able to help you out, right?
It definitely was. After so many different neurologists that I saw, all saying there was stuff that there was nothing wrong, it was definitely nice to finally hear somebody say, we figured it out and we're going to fix it.
All right, let's bring in the heart connection. That's why we have Dr. Ramirez with us. Tell us about what are the long-term heart effects if you have seizures and they're not being treated properly?
First of all, Jenn, that smile tells it all.
It does.
You know, I think it really, you can tell it's been a life changer for you, and Dr. Ulloa, you know, great work on that. So with seizures, you know, seizures are very common. And one of the things in terms from a heart perspective, the things we are, you know, concerned about is whenever you have a seizure, there's a lot of things that happen to the body, right? And so one of the things that happens to the body is that you tend to have, you know, you have a change in your respiratory drive. Sometimes patients don't tend to breathe, you know, as well, and sometimes it's suppressed. And when you have suppression of the respiratory drive, that can also promote and cause a slower heart rate. And these slower heart rates can be significant. You know, there's a combination when the respiratory drive is depressed that basically you have a higher tone of what's called the rest phase of the adrenaline system. And that heart rate, you can even have long pauses. You know, sometimes even a pause greater than 6 seconds may lead to a fainting spell. You know, but it's not uncommon to even see pauses longer than 10 seconds. And that's when things really start to get scary and start to get concerning for us, okay? A lot of times, you know, what happens is, you know, sometimes if you have a seizure while you're asleep, you know, those are the reasons why some patients may not wake up in the morning, right? And all of this is very scary, okay? But I just want to reassure you all that this is still incredibly rare, okay? But the treatment for this, and like in Jenn's case, you know, she went 20 years without a diagnosis. It wasn't until she had that episode where she had that grand mal seizure that, you know, she was able to get, she's like, I need to do something about it. Let's get to the right location. But the longer you are without treatment for these seizures, the higher the risk, because the more episodes you'll have, and there's always going to be that risk of having those long pauses, okay? Now, in terms of epilepsy heart, you know, so there's this term that's out there that says epilepsy heart, and basically epilepsy heart is a condition. It's the term that we use for what is the risk associated with patients who have epilepsy in terms of their cardiovascular health. So we all know that the general population, we have to do all the right things, right? We got to exercise, we got to eat well, you know, get good sleep, all those stress reduction things that we need to. But we also know that some patients with different comorbidities will have a higher risk of accelerated, risk factors for coronary artery disease, which is the predominant cause of death here in the United States and across the world, okay? And so patients who have epilepsy are at higher risk, and the reason for that is because there tends to be a spike in the adrenaline phase in the body whenever you have an episode as well. And that adrenaline can lead to high pressures. It can lead to all sorts of stressors on the heart itself. The heart has to work harder. And all of that over time, the more episodes you have, the more of a stressor you have on the heart, and that could lead to acceleration of some heart disease.
Epilepsy heart is not a term I had heard until just today when we were talking, because again, I don't think it's something when we talk about brain and heart, but again, that's why we have the show, because everything is connected, right?
That's right.
That's right. Hey, Dr. Ulloa, okay, let's do a little show and tell, shall we? I know you brought some photos. They are not of Jenn's brain, but maybe you could help us understand what we're looking at when someone is actually having a seizure.
So this one actually is of Jenn's brain, and so left and right are backwards. So it's actually on the left side of the screen, but it's her right brain is where the lesion was in the inside part of her temporal lobe, in the amygdala. And the amygdala is actually our kind of fight or flight center. So when you stimulate that area, panic and sort of that adrenaline rush is one of the things that can happen. And so that's where her abnormality was. It's subtle. It's definitely something that I would say most places would not pick up, but it's there, and it fit perfectly with the seizures she was having.
What causes
this
epilepsy?
This is a functional MRI, and this is a specialized type of MRI that maps out your motor functions, your language functions, and it becomes obviously important when we're planning surgery. Those areas, those vital areas need to be mapped out so we know what to avoid. And this is another kind of fancy image, something called an ictal spect. Jenn did not need to have this test, but it's when there's not an MRI abnormality. And so level 4 epilepsy centers, we still are able to do surgery in people with normal MRIs because there's other images that can pinpoint the area of seizures. This one's interesting. It was another extremely subtle MRI lesion, and that's actually where the crosshairs is. And actually, I have to give props to Dr. John Lever, our neuroradiologist, when I kind of said, let's take another look at this MRI, because I really think there's something there. He was able to find it. And that patient actually ultimately went on to have surgery, and he actually, rather than being able to go straight to surgery and remove the lesion like Jenn did, he had to have electrodes placed within the brain, stereo EEG, to kind of further localize the epilepsy, and that's what this illustrates. This is a seizure on that, coming from that study, from that EEG study. And I think even someone who knows nothing about epilepsy can see in the middle of the screen, all of a sudden there's this change that takes place, and that's the seizure. This one just shows the different anatomic areas of the brain.
Dr. Ulloa, it's so complex. It blows me away. You could just look at this image and know what the next steps are. Tell people what causes epilepsy. Before they come to you, how does this come to be?
In a basic sense, it's that there's kind of a hyperactivity of the brain cells, but the causes can really vary. Genetic is a big one, and it doesn't mean that you have a parent that had it, but there was either a new or a passed on abnormality. Head trauma, brain infections. As your brain is forming in your mother's womb, the brain has to form, and sometimes there's just little abnormalities that can cause no other problems other than epilepsy. And then anything that affects the brain, so brain tumors, strokes, inflammatory disorders, so autoimmune disorders is an up-and-coming field, dementias and cerebral palsy, and really there's many others. Essentially, anything that affects the brain structurally, where it kind of injures the brain can then lead to seizures.
Help us better understand what SUDEP is.
So SUDEP, sudden unexplained death in epilepsy. And it's something that when I started practicing, and probably still now, a lot of doctors don't really tell their patients about it because there's this, I don't want to scare them. Do they really need to know? But I think we do need to raise awareness. And it basically means an otherwise healthy individual, with a general good state of health who has epilepsy and has a sudden unexplained death, whether witnessed or unwitnessed, most often related to a seizure, but the seizure itself does not have to be witnessed. And it's not due to some other cause, like they hit their head and they had a head bleed, or they drowned because they had a seizure in a pool of water. So otherwise unexplained. We make the definite diagnosis if the person has an autopsy that shows no other cause of death. But even without an autopsy, when you exclude other factors, then you are able to make the diagnosis.
Really scary. So is anyone who has any type of seizure or anyone with epilepsy, are they prone to possibly SUDEP?
So I think what Dr. Ramirez said is important, which is we don't want to scare people, meaning this is not something common. And there was a study that looked at about 250 patients in childhood and followed them for 40 years to see how many people had this, type of death. And it was about 7% of them died of SUDEP. So it's not utterly rare, which I think in some cases we thought it was, but it's also uncommon. However, there are people who we know are at higher risk. And who are they? Number one, they're still having seizures, meaning they're uncontrolled. They take medicine, but it's not entirely taking care of the issue. And number two, the big seizures, what used to be called grand mal, the what we call bilateral tonic clonic seizures now. But those are the ones that most people think of when you think of a seizure. The person collapses, they stiffen, their body shakes very significantly. And those are the kind of seizures that if you continue to have those, particularly 3 or more per year, it increases your risk.
Well, I think you bring up a good point. It's not a scare factor, but this is why we want to keep things in check, because we don't want people to get to that point. Jenn, tell me a little bit about the types of seizures you were having. What was the experience like? Help us understand kind of a day in the life.
So for the most part, what it was is I would get like this aura feeling, and it would make me very dizzy and kind of just out of it. And then it would happen back to back to back. So I kind of had clusters of them. And I would just get really exhausted afterwards. So I would just literally have to sleep for a while. But the biggest thing was dizziness, and then the deja vu aura. And then it just kind of felt like the whole world was shifting.
Really scary. But you're almost 5 years seizure free. So that is good news. I want to ask both of our doctors on the panel, tell me what that conversation is like. If you do have a patient that is referred to you, doctor, so what are the conversations like with perhaps Dr. Ulloa? What is that communication to make sure that the patient's best taken care of?
That's right. So in my practice, the majority of patients I see are patients who come in with a fainting spell, for example. But because if you think about it, when patients have a fainting spell, they could also have all of those body movements and signs that suggest a seizure, right? And so many times you'll talk to a patient and, their relative, and they'll say, yeah, she lost consciousness, but it looked like she was having a seizure, And so when they come in, I basically initiate my initial workup for those patients who have fainting spells or syncope, which may be anything like a monitor, an ambulatory monitor. If that ambulatory monitor is negative and I don't have another reason to explain why she had that event, sometimes we do a longer monitor, sometimes something we implant underneath the skin and it will sit there and monitor. But at that point in time, if I'm starting to rule out things, the heart's nice and strong with an echocardiogram and ultrasound of the heart, the monitor looks good, maybe I've done some additional testing, I really start to think, is this more neurological? And a lot of times that's when, my neurology colleagues always come to the rescue, right? So I can reach out to them and say, hey, she's having these events. I'm not seeing anything on my end. Can you take a look at it and give me an assessment and see what you think? And at that point in time, they initiate their workup and we work together.
Yeah,
to
that
get
comprehensive care. That's what's so great about
right.
being here is that it's like somebody's down the hall saying, I got to ask you a question, and you can rule things out quickly, right?
It's very easy here. I think one part of it, I think we reach out, our neurology colleagues are readily available. I think, we always try to work in patients if we need to sooner, if we think they're high risk. And likewise, I think we try to reciprocate that for them because this is all very anxiety provoking and we want to get down to the bottom of it as soon as we can.
As soon as possible. Every second counts. Very reassuring. Dr. Ulloa, you instructed Jenn to undergo a unique surgery. Tell us a little bit about what that entailed. And we're going to show some photos along the way.
Yes. So basically, it was Dr. Paul Camarada performed the surgery. And so he had to make a window in the bone to be able to reach that part of the brain. And that's what you're seeing there is the incision. And then when it was stitched up after the surgery. And then essentially removing that abnormality that we saw in the MRI. The nice thing is that it was a small area of the brain. And so sometimes people required larger portions, of surgery of the brain removed. For Jenn, it was really a fraction of a typical surgery because there was such a, nice lesion that we were targeting. And we also do the EEG monitoring during the time of the surgery just to guide okay, did we get it all? The tissue can have the abnormal electrical signal on the EEG. So that helps the surgeon as well. And then Jenn, I think you probably were in the hospital, maybe 2 or 3 days or?
Yeah, only a couple days. I think I went in on a Thursday and got out on a Sunday.
Yes.
In and out. We like to hear that and doing well. Jenn, I have to note that and Doctor, you mentioned it, just that smile says everything. Yeah. It must be incredible to have your life back. I remember when we first spoke several years ago, you said, I just wanted to be able to jump in the car and go get a Dr. Pepper whenever I want to. You got that Dr. Pepper next to you, don't you? It's always with you. How does it feel, though, just to grab your keys and be able to get behind the wheel of a car safely again?
It's nice. It's definitely nice just to be able to get up every morning for a Dr. Pepper. But just to go out and explore, I do a lot more things that I used to be able to do.
Well, you take for granted those little things.
Yeah. Going to the lake and just everything has really opened up since my surgery.
Well, I want to get to some community questions if we can, because we've got a couple of really good ones here. And the first one is a comment actually from Bridget. And she says, 2 of my favorite ladies, Jenn and Dr. Ulloa, just talking about how fantastic you are, doctor, and just how professional you are, and just thank you. And thanks to Jenn for sharing the story. So little shout out to both of you. Thank you so much for that. Sharon wants to know, what is BECS in children?
Oh,
are you familiar with that?
Oh, B as in boy. B as in
B
boy.
as in boy. Yes.
So that is a benign epilepsy. Well, we call it benign because they can outgrow it. It starts kind of in the centrotemporal part of the brain, and often it's seizures in your sleep that commonly affect your face, like you might have twitching of your face, but then it can go on into the grand mal seizure. And it's a childhood epilepsy, meaning it's one of those that tends to occur in that age bracket. And commonly and thankfully, even though the seizures can be harder to control initially, often the child can outgrow it, but they don't all do so.
Well, that
but
could be
it
kind of
requires treatment, with
yeah.
medicine.
That could be scary for a parent. Now, Sharon went on to ask a follow-up to that. Should a child have a second opinion on an MRI that shows no lesions? The doctors didn't find that, but sleep deprived and EEG shows seizures.
Yeah. I think the question of a second opinion, and I'm sure Dr. Ramirez can agree, is always an important one, because you want to have the right answers. What I would tell people specifically, and what I do, is that number one, you have to be satisfied and comfortable with your physician. It is a relationship that, is just a very unique patient-physician relationship, and you have to be satisfied with that. If you're not, I would say you do, seek care elsewhere. The second thing is, though, if the person is doing well, they're not having seizures, they're not having problems with their medicines, probably less necessary to get a second opinion. But it becomes very necessary if you're not getting better. The seizures continue, and despite the things that your doctor is trying, it's still, not going away. And then I think it's vital to have a second opinion.
Doctor, tell me a little bit about what happens. Alicia wants to know to the heart when a seizure is happening. I think you mentioned a little earlier, but go over those signs again so people know they need to call a doc.
You got it. So basically, when you have a seizure, your body just is very, it's very unpredictable, right? So, as just what you see with the body where it's contracting in different locations, that chaos can happen in other parts of the body, okay? But like I explained earlier, the main reason why you have, you're at risk for developing heart complications during a seizure is because, your breathing is also affected. And so everything's connected, right? So if you think about, if you're having a seizure, your breathing's affected. If it slows, and slows significantly, you can actually start to have long pauses, or you can start to develop, what they call, block, where the top chamber of the heart and the bottom chamber don't communicate, okay? The other thing is that in terms of the heart is that the brain also is in control of all of what they call the autonomic system, which is what controls a lot of your reflexes, And so that also makes it very difficult for, your body to just control those in that certain instance when the event's happening. That combination is what can lead to a very long pause. The longer the pause is, the less flow you have to the brain, and that's when you could actually develop that dangerous rhythm that could lead to sudden cardiac death. Okay. Now again, I re-emphasize this, that it's extremely rare for that to happen. It's probably, I think the last research that I read was 1 in 1,000 patients with epilepsy are at risk. So 1 divided by 1,000, very low. 999 patients would never experience that. Okay, so.
That makes us
Jessica,
feel a little more reassured. Dr. Ojoa?
Yes, if I could add, the most common thing is a fast heart rate. And that we actually don't get too concerned about, because it's so common that the heart rate goes up during a seizure for the reasons Dr. Ramirez mentioned. The strange thing is how in those serious situations where it goes into something, worse and potentially the SUDEP, is the opposite. Is the heart rate actually slows down and slows down to a point where it stops. And sometimes it's a perfect storm. So because the brain controls everything, as your respiration is going down, also you don't have the wherewithal to say, okay, I need to, arouse myself so like I can wake up. The person is usually obtunded, meaning they're sleepy. They might end up face down on the bed, belly down, which is even worse, because then your breathing mechanism is even harder to expand your chest as much as you need to. So it can be this perfect storm of things that then can lead to a negative, situation. But again, yes, rare.
Let's talk about something we can control, our food and diet. Corey has a keto question. What effects do the keto diet have on the brain? Do they stop seizures? Can it stop seizures?
Yes, so it's one of the non-medicine treatments that are available for epilepsy. And so it's particularly for patients where the medicines are not working. We don't know exactly how the ketogenic diet helps with seizures. We don't entirely understand it, but what we do know is that it changes how your body is using energy. So instead of using carbs for energy, it's switching to using fats for energy. So thereby the diets, which there's several of them, the 4 are listed there, are low on carbohydrate, high on fat and protein, and pretty high on fat. The classic ketogenic diet is a lot more challenging. You can tell it's like a great amount of fat compared to something like the modified Atkins diet or the low glycemic index diet. So that's why sometimes those are easier to do. It is not necessarily a cure for epilepsy, but it's something that can lower the seizures. And usually what I tell people is, half of the people who stick to the diet can lower their seizures by half. So it can have a significant impact, but you have to stick to it. Once you're off the diet, then the metabolism, your body goes back to, not being in ketosis, which is the where it produces the ketone bodies from using the fat for energy.
Dr. Ramirez, I can't have a heart doctor on here and not ask your thoughts on the keto diet.
Yeah, so I'm a fan of the keto diet. I think same for the same reasons Dr. Ojola just mentioned, but some of the basic effects is that the keto diet, really focuses less carbs and it focuses more on the lean meats and nuts and berries. And what happens with that is there's a reduction in inflammation. So when you have a reduction in inflammation, that helps the entire body. And the other thing is, it's a lifestyle. It's a lifestyle change. It's difficult to do, but it also helps you control your cravings and also controls your cravings and you eat less. So overall, very good for the heart too. So I recommend it.
Good all around. Jen, couple of questions for you. Denise is wondering how you survived emotionally, not getting those answers to your issues sooner.
It was kind of challenging. It took a long time. With everybody keep saying that it was anxiety. I was like, I know it's not. So it was a struggle because I knew there was something and nobody else was really coming up with it. So I got through it, stuck strong with my faith. My faith is a big thing for me. And that really got me through all of those different years.
Another question is the triggers. Did you have triggers? Did you know they were coming on? And if so, what were they?
I don't know that I necessarily had triggers. It just seemed like it would happen all the time. So I know a lot, like with the flashing lights and stuff like that, that really wasn't a trigger for me. It was kind of around my cycle. And so that was a trigger. I knew it was coming up around that time. But towards the end, it was happening all of the time. It wasn't just certain times of the month. So it kind of evolved and changed.
Candace wants to know, could these seizures be hereditary?
They can be. Genetic testing, for example, can sometimes help us understand that further. And we kind of, we don't do that necessarily on every patient with seizures, but on patients where we think it could provide useful information. But definitely there is a hereditary aspect to it. But I think the other thing I want to highlight is that when your doctor might say, this is a genetic type of epilepsy, it doesn't necessarily mean that it's familial. It doesn't necessarily mean that it's passed on. It can be what we call de novo, which means sort of a new, you use the word mutation, sort of a new abnormality within your own genetic makeup that's causing an abnormal protein or an abnormal channel in your brain that then is developing into the seizures. So, but absolutely, they can.
Bridget wants to know what caregivers can do to help their loved ones when their breathing pauses during a seizure. Some may or may not have a rescue bed. Does one begin CPR at that point? What advice do you have?
Yes, I mean, it's a perfect question, and thank you for that question. And it carries its challenges, to really be able to say exactly what to do. But from what we know about SUDEP, what you should do is, for example, that safety position. So if somebody is face down, belly down, get them onto their side. That will help with their breathing. Stimulate them. So, that kind of rubbing them on the chest, that kind of trying to wake them up. Believe it or not, that actually helps, because we know that SUDEP more likely is going to happen in somebody who has a seizure in their sleep at night alone. And then they have no one that's trying to wake them up. They have no one to turn them over and that sort of thing. And then time it. So time the seizure. And anytime a seizure is going past that 5-minute mark, we find that to be a medical emergency and would call either have a plan that you have with your physician as far as what you do at that point, whether it's a type of rescue medicine or calling 911. I think there are people who may find it useful to have, depending on the situation. This is where there's so much variability because epilepsy is one term for 1,000 different situations. But sometimes having monitors, for example, in the bedroom of someone who is known to have seizures in their sleep can be useful. And so I think it really has to be an individualized discussion with your doctor, but they're very important discussions to have.
Great conversation and great advice. Thank you so much. We're going to get our final thoughts started. Jenn, I'm going to start with you. And thank you again so much for sharing your story and being with us here today. We appreciate you.
So my biggest thing is I would recommend not giving up, because for so many years people told me that there was nothing wrong, and it came across that there was, and we found it and we fixed it. And so if I hadn't kept going, pushing forward, then I would still be having seizures today.
Well, we're so glad you're back to life doing well, and you're going to stay in touch, right?
Of course.
We'll keep bugging you. Seeing how you're doing. We want updates. So good. All right, Dr. Ulloa, thank you again for being with us. Final thoughts from you.
Thank you so much. I think have a doctor that listens. I think that's a big thing, is someone that's listening to you.
Know your body. Speak up, right? Dr. Rivera is great. Thank you so much for being here with me today.
Thank
Final
you.
thoughts from you.
I learned so much in these things, and I think that's part of the beauty of being able to, log on and learn about it and do different topic. But, just like I just want to reemphasize, these things are rare, but I also want to reemphasize that there's help, and, we're here to help. And when you don't get the right answers the first time, that's why, just like Dr. Ulloa said, if you don't feel comfortable, it's okay to get that second opinion. Advocate for yourselves. So.
Absolutely. Gosh, if you're learning a lot, imagine how much the rest of us are learning.
Mm-hmm.
I always think of you as having all the answers. So, all right, everyone, thanks so much for being with us. Couple more quick things. The Epilepsy Foundation of Missouri and Kansas is hosting a special gala for Epilepsy Awareness Month. It is Saturday, April 30th at 5 p.m. at the Carriage Club. Individual tickets will cost $125. It does include dinner, valet parking, and $1,000 in chips to play some casino games. You can purchase those tickets using the QR code there on your screen. The University of Kansas Health System, we will also be there because we are one of the evening sponsors. So it should be a fantastic night. Hope you could join us. You may have seen this headline. A new study says avocados reduce the risk of heart attacks. Well, the study in the Journal of the American Heart Association found that eating at least 2 servings of avocado a week reduces the risk of having a heart attack by 21% compared to avoiding or rarely eating avocados. But that doesn't mean you can have an entire bag of Cheetos and then add an avocado and then all of a sudden you're heart healthy, right?
No, dipping your Cheetos in avocado doesn't help make your benefit better. It means you have to make a committed or a focused effort at, yes, knowing what a heart healthy food is, a cardiovascular healthy food is versus what isn't one. And it has to be a sustained and just a way of living, way of eating.
It does make your avocados taste better with the Cheetos, but 1 serving of avocado, get this, is just about a tablespoon. So that's just a recommended 2 tablespoons of avocados a week. So don't overdo it. Doctors say it's all about consuming the good fats. Avocados have 0 cholesterol. They are sugar-free and a very good source of fiber. So eat up. Thanks again so much for being with us today. Next week on All Things Heart.
Was kind of getting short of breath, but I just thought it was, well, I'm getting older and out of shape.
Fitbits, Apple Watches, how a fitness tracker found a life-threatening condition. That's coming up next Thursday at 10. Have a great day. Thank you so much for joining us this morning for this Best of All Things Heart. We love sharing these important stories with all of you. So remember, you can always email us at allthingsheart@kumc.edu, or you can reach out to us on Facebook, Twitter, and on YouTube. We will be back with live shows focused on all things heart every Thursday morning starting September 8th. Go out and make it a great day.